Next, we'll discuss liver anatomy. This is complicated anatomy, so let's work through it systematically. The first thing to note is that the picture shows a portion of a lobule of the liver, which includes many of the functional structures. Individual hepatocytes have two surfaces: an apical surface, which faces the bile canaliculi, and a basolateral surface, which faces the sinusoids. The sinusoids drain to the central vein. Blood flow comes from the outside of the lobule through the hepatic artery and the portal vein and feeds centrally into the central vein, which then leaves the liver through the hepatic vein. Bile flows from right to left as it leaves the hepatocytes through their apical surface and flows through the bile canaliculi into the bile ductules at the ends. Given this anatomy, different zones of the liver are affected in different ways by different insults. Zone 1 is the zone around the portal vein, which is affected first by viral hepatitis. This might make sense, as blood carrying the virus will hit these cells first. Zone 2 is known as the intermediate zone. Zone 3 is known as the pericentral vein zone. Since blood flows from out to in, it's not surprising that blood flow reaches this part last, so in situations where ischemia occurs, this central zone will receive blood flow last and will therefore be the most sensitive to anoxic injury. This zone also contains the P450 system, making it the site of possible toxic injury. It's also the main area affected by alcoholic hepatitis. Alright, we've covered a lot of abdomen, but we still need to mention the gallbladder and related biliary structures. Let's get oriented to the diagram. Here we have the gallbladder, duodenum, and pancreas. The bile that's produced in the liver exits via the right and the left hepatic ducts, which merge to form the common hepatic duct. Some bile travels up the cystic duct for storage in the gallbladder, and bile also travels out from the gallbladder via that same cystic duct, at which point the channel is known as the common bile duct. The common duct travels inferiorly through the pancreas and combines at some point with the pancreatic duct, which carries pancreatic secretions. These two ducts merge and empty their contents into the duodenum through two regions with very special names: the ampulla of Vater, which refers to the duct lumen, and the sphincter of Oddi, which controls the opening and closing of the duct. When you think about gallstones, it's important to know at what point in the duct system the stone or stones are obstructing. In some cases, they can reach the ampulla before getting stuck, and there they would block both the biliary and the pancreatic ducts. Tumors can also arise in this region, pancreatic cancer being the most typical example, and cause an obstruction that eventually leads to the classic sign of obstructive jaundice. What do we call the situation where a gallstone is obstructing the common bile duct? This is choledocholithiasis. Chole obviously referring to bile, doko coming from the ancient Greek word meaning passageway, and lithiasis meaning stone. See, if you know the Greek and the Latin, the name gives it away. We'll review the femoral region very briefly. The key mnemonic here is navel, N-A-V-E-L. This tells you the lateral to medial structure of the femoral region. The femoral nerve is the most lateral, and as you move medially, you'll encounter the femoral artery, vein, a gap of empty space, and then the lymphatic vessels. The femoral triangle is bounded superiorly by the inguinal ligament, medially by the adductor longissimus muscle, and laterally by the sartorius muscle. This triangle contains the femoral vein, artery, and nerve. The femoral sheath is a fascial tube below the inguinal ligament that contains the femoral vein and artery, as well as the canal, but does not contain the femoral nerve. This is a diagram that provides a detailed view of the inguinal region. We should first get oriented to the diagram. The internal abdominal wall is here at the top of the diagram. The skin, which is not shown, would be at the bottom, and we have the medial on the right and the lateral on the left. From outside to inside, we know the layers are the skin and fascia, which are not shown, and then the external oblique muscle, internal oblique muscle, transversus abdominis muscle, transversalis fascia, and then the peritoneum. The peritoneum has two layers: the parietal peritoneum that is attached to the abdominal wall, and then the internal visceral peritoneum that's attached to organs and not shown here. This is another common set of terminology you'll see, visceral versus parietal. Obviously, the easy way to keep it straight is to remember that visceral is covering the viscera or organs. That's the mnemonic I like to use anyway. The main advantage of this diagram is that you can really see where specifically the spermatocord travels and use this to understand two main types of hernias. The spermatic cord, which is only about 4 cm long, travels inferomedially and acquires coverings from various abdominal wall layers. You can see here that those layers are the internal spermatic fascia, cremasteric muscle and fascia, and the external spermatic fascia. The external spermatic fascia, which is added last, comes from the external oblique muscle. The cremasteric muscle and fascia are from the internal oblique muscle, and the internal spermatic fascia is from the transversalis fascia. If a region of intestine protrudes through the internal inguinal ring, it's considered an indirect hernia. However, if the ring and cord are not involved, and the hernia instead protrudes right through the abdominal wall, this is considered a direct hernia. You can also see that the direct hernia is occurring medial to the inferior epigastric vessels, while an indirect hernia occurs laterally to the inferior epigastric vessels. Now we'll review 4 types of hernias in more detail. A hernia, as you know, is simply a protrusion of peritoneum through an opening, and the hernias we're interested in are indirect and direct inguinal hernias, which we just mentioned, and diaphragmatic hernia and femoral hernias, which we'll talk about in a second. Again, the indirect inguinal hernia goes through the internal inguinal ring, and after passing through the spermatic cord and external inguinal ring, goes into the scrotum. As you saw in the diagram, this occurs lateral to the inferior epigastrix. In infants, it can occur if the processus vaginalis fails to close. The direct inguinal hernia goes right through the abdominal wall, medial to the inferior epigastrix. This is an area known as Hesselbach's triangle. Direct hernias don't pass through the internal inguinal ring, but they do go through the external inguinal ring. The direct hernias are commonly thought to be associated with congenital weakness in the abdominal wall, or heavy lifting on exertion, but study results are mixed. A mnemonic you could use to remember the difference is MDs don't lie. This reminds you that medial to the inferior epigastrix are direct hernias, and lateral to the inferior epigastrix are indirect hernias. 2 other important hernias are the diaphragmatic hernia and the femoral hernia. A hernia that occurs in the diaphragm allows abdominal structures to enter the thorax, and if the opening is large during fetal development, this can impact lung development. Hiatal hernias are the most typical type of diaphragmatic hernia, and here the stomach herniates through the esophageal hiatus into the thorax. Sliding hiatal hernias are the most common subtype, where the gastroesophageal junction is displaced. Paraesophageal hernias can also occur, with a normal GE junction, and the cardia of the stomach is displaced into the thorax. The final hernia to mention is the femoral hernia, which is more common in women. Here there's a protrusion below the inguinal ligament and through the femoral canal, and this is an important cause of bowel incarceration. This diagram provides us a broader view of the region of interest, showing us the critical inferior epigastric vessels and the sites of different hernias. You can see that Hesselbach's triangle is formed by the inferior epigastrix, the lateral border of the rectus abdominis, and the inguinal ligament.